the presentation. Okay, great. Well, welcome to everybody who's here in person. There's also a number of folks who are here virtually from a variety of different places, countries, locations, departments. So this is our first works in progress meeting for the Center for Global Surgery for this academic year. And I'm the director of the center. My name is Sudha Jayaraman. I'm one of the trauma surgeons here, trauma and critical care faculty. Thanks for coming all the way down here. My goal is to introduce you to our center today, a number of different activities and programs, so that if you're interested, there are ways to get involved, or there are ways to kind of attend some of the things and kind of keep it on your radar as ways to stay engaged, especially if you're going through training, when you really need that light to keep you energized through those long days and nights of becoming the kind of person that you want to grow up to be. So hopefully this will keep giving you that sort of inspiration and motivation. Hopefully some of the folks that you'll meet in person and online will also help you think about that. This is our works in progress meeting. Occurs generally on a weekly basis, often online, typically around lunch hour. We'll tend to have different speakers from really anywhere around the world. A lot of it depends on time zones. So sometimes the hour will move because we have people in Mongolia who might want to share their work. And so they're 10, 12 hours away. Or we actually have a speaker later this fall from India who will be speaking at 11 p.m. his time. And so we're trying to kind of create our community across the globe. And anybody is welcome to attend any of these things and participate in any of the projects. So, so that's where I'll start. I don't know how to make this go away. Put this marquee down here. Will it go away if yes, it will. Okay, cool. So as I mentioned, I'm a surgeon. This is for the Center for Global Surgery. And you don't think about global things necessarily when you think about operating. You think about taking care of patients, service, and think about, many of you may have seen various like ads or clips online for different organizations that do wonderful things around the world. And so that service is what drives all of us, right? That's why we're all here. We want to be able to make the world a better place. And there are lots of fantastic organizations that do that and have done that for generations. But over the course of the last 20 years or so, there's been some thought of, how do I actually scroll? Of hey, who needs surgical care? And who's getting surgical care? That seems like a reasonable question to ask, right? And so turns out about 15 years ago now, Tom Weiser, who's now a surgeon at Stanford, did this study. I made up this graphic based on his paper, but basically showed that a lot of surgical care occurs in richer countries around the world, which sort of makes sense because you need kind of infrastructure to be able to take care of those patients. But what that means is that a lot of surgical care is not delivered in parts of the world where the majority of the world's population is. And so then it's like, wait, this is a total disconnect. How do we add this up? So that also led to this recognition of, well, US surgeons being part of these wonderful missions and organizations is all well and good, is important, because we all need to be inspired, right? But it's not enough to address the need in many places. So you need to think about, well, how could we create collaborations that enables that kind of infrastructure to be formed across the world? And so the Lancet, which is obviously many of you know, probably all of you know, is an important surgical journal or important medical journal worldwide, puts together these different commissions, like basically teams to go around the world and collect information to say, what can you know about this topic? So for example, right now there's a commission on women, power, and cancer. So think about, if you were studying breast cancer in rural India, like imagine what the hierarchy and power differentials might be, and how that might affect care, right? So that's a commission that's happening right now. In 2015, the Lancet had organized and published a commission on global surgery saying, this is the first time anybody's systematically looked at surgical care worldwide to say, what's provided, where, what are the needs, what is the data, what is the infrastructure, what is the workforce, what is the quality of care, what should be the quality of care. Many of you will know over the course of your training that you'll come across things like maternal mortality or infant mortality, to really establish metrics of care for a lot of health systems. Well, turns out there isn't necessarily something specific that everybody's agreed on for surgical care. And so this attempt tried to kind of standardize that worldwide. Like, so if you're in rural Utah, what should be your metric for surgical quality? What should be your metric in rural Australia, in the Aboriginal population? You need to have something, right? So, and that was the conversation that developed. And I'll point out a couple of different people who are in the room, who are involved in this commission. Ray Price, who's in the back there. Ray, wave up to everybody. And Catherine DeVries, who's in the front here, who were key part of this effort, like worldwide effort for the first time. I was also part of it, but more on the side of not doing the work, but reviewing the work. And so that work for the first time said, actually, most of the world's population doesn't have access to surgical care, and a lot of operations are needed and just aren't done. So that's like 140 million additional operations per year are needed, are just not getting done. And that it's really expensive and people become impoverished if they seek surgical care. And this surgical care also includes things like C-sections. You don't think about C-sections as surgical care, but it's important. And you don't think about cancer care as surgical care, but you need to remove cancer. You don't think about a child who gets hit by a car walking to school and breaking his or her leg as part of surgical care, but trauma care is part of surgical care. So all of these different things are important. So, and they tried to quantify all of those things. And they also kind of said, well, what do we really need to care about surgery, right? In global health, like it's about primary care, it's about access to care, it's about vaccines, about water and sanitation, it's about all of those big important systems. Why should we really care about surgical care? And it turned out that when they did the systematic analysis, about a third of all healthcare was related to surgical care, a third. So if you don't think about surgical care, then you're like just giving up on a third of patients, which doesn't make any sense. So that's part of the momentum to say, oh, actually, maybe we need to think about this a little differently. And very few numbers of procedures occur in what you'll see as low and middle income countries, so poorer countries. There's a language there where you'll hear developing, developed, low income, high income, low resource, high resource. Are any of you from rural parts of this country? How well resourced are those parts of this country? Poorly resourced? Anybody from any of the reservations? How many of those reservations do you think feel developed and high resource? None. So the language is all messed up. Nobody really has a good way of describing these needs. There are significant needs in our own backyard and applies to every country around the world. But the focus in 2015 was thinking about low and middle income countries to say surgical care, because the papers before that said that's where there wasn't enough need that was being met, right? That was that imbalance of need. And they also tried to quantify, like, what if you just didn't do? You said, you know what, that third of the population doesn't matter. It would have huge economic impact. And so they tried to quantify that too, to say, actually, there's legitimate reason, not just because of lives saved, but also because your countries can't develop if you just say, oh, that kid didn't need his leg anyway, right? So you need to have like that kind of thought. So there was this growing momentum to say the humanitarian focus is really important. It's not enough. And it really centers the richer countries and the surgeons in richer countries, and not necessarily the patients in poorer countries who perhaps need the care. And so there's been this mindset change, and Ray and Catherine have been critical as part of implementing that change, creating the momentum for that change, and thinking about surgical care as surgical systems and developing new language to say it's not just about going somewhere and doing an operation, but it's about enabling systems to develop that can deliver those services at good scale and at good value. And not just surgeons, because you don't need just a surgeon to do an operation. You need nurses, you need pharmacists, you need technicians, you need all these other folks. You can't just like put a surgeon and say, give me a scalpel, great, I'll just go stand by the corner of the street and do an operation. You need all these systems to exist, right? So how do you think about that? So this language coined by the people in this room at this institution is some of the most recognized language. By the way, that is published in one of the main textbooks in surgery. So like we've literally set the bar worldwide for thinking about surgery as an important part of healthcare. And so really there's this concept of you need all these different disciplines. How do you work together across all these different disciplines? How do you create systems to deliver surgical care? And so that's what a lot of our group tries to do. And it's really thinking about not even teaching people to fish, but knowing that there are ways to fish and ways to improve systems and improve access to needs around the world. And it's all about this change in paradigm. Go from like, can we send a surgeon to do 5 cases in that day? Or can we help support surgeons and nurses and pharmacists in various places so they can continue doing 5 cases a day forever? And that has to do with education and training. It has to do with developing systems. It has to do with developing local evidence. Like what works in rural Utah, do you think that same thing will work in New York City? Maybe not. What works in rural India may not work in London. And what works in London may not work in rural India. And so how do you then figure out like what's going to work in that setting? Who knows that setting best? Like any of us who go there for 3 days? No, probably not. Most likely not. Has to do with folks in those environments who then kind of work on developing the evidence and then developing innovative solutions to those problems, right? So this is a picture of a lot of our faculty, probably not all, who are involved in our Center for Global Surgery. So Dr. Doris is on the top left there and Dr. Price at the bottom. And this is including transplant faculty and breast cancer faculty and folks from a variety of different disciplines who over the last number of years have grown this center. And this is actually the oldest center for global surgery in the United States. And kind of really push this mindset of we have to think about surgical care differently. So this is what our group envisions is how do we ensure that there's safe, effective, affordable care worldwide? And we work across not just the School of Medicine, which a lot of you are from, but from partners across the university, School of Nursing, School of Business, School of Social Work, to partners around the world, on practically every continent. I don't think we have a partnership yet in Australia or Antarctica, but practically every continent and major societies around the world. Because again, we've been around for a long time, comparatively, compared to most other surgical programs, global surgical programs. So we've been around for 12 years, and I'll tell you a little bit about what all we've kind of been involved in. So advocacy is a major pillar for things that we're interested in. So in 2015, after that big publication from the Lancet, there was a push to say the World Health Assembly, which is basically the meeting every other year of all the health ministers of every country around the world coming together to say, what are our priorities? What should we all be working toward? Well, Dr. Price, Dr. Doris, and a group of folks championed, worked across countries to enact a resolution on saying that surgical care has to be part of universal healthcare. And that has to be thought about. So every country has to think about what delivering surgical services should look like in their setting. Because again, third of population, third of the healthcare needs are surgical related. So you can't like ignore that. But at that level, at the UN, at the World Health Assembly, we've been involved in advocating for surgical care and the needs of the surgical patients. I mentioned the Lancet Commission, and then being part of a variety of different international organizations, helping stand up a variety of different international organizations, working with people from WHO, from surgery, from trauma, from American College of Surgeons, et cetera, and then more recently working with our own government to say, well, Congress, you should be putting money into neglected surgical conditions worldwide, not just HIV and TB and malaria, which is what most people think of when they think of global health, but really should be putting money towards surgical systems, which, by the way, will then help with all these other things too, because you're supporting systems and not just like one disease, managing one disease at a time. And probably many of you may not know this, but through the COVID pandemic, there are a lot of surgeons and anesthesiologists involved in providing critical care and respiratory care because they've been trained in it. And so there's a lot of resources that were being mobilized that had to do with surgical systems, that places that didn't have those systems like couldn't mobilize. So most recently, there's been a push, and I think Ray can probably tell more about this than I can, to push on our government to say, allocate millions of dollars. Really, we wanted much more than this to work on different programs. So what are programs that we've been involved in? So in the Center for Global Surgery, which is actually a center that bridges OB-GYN and surgery in the university, in the School of Medicine here. How do we think about programs across the scope of those fields? So the OB department has largely been working on oncology related research in a couple of different places in Ghana and Nepal or Rwanda, working on setting up oncology training programs, because cervical cancer is a big cause of death worldwide. And so we need to be thinking about how do we improve that. It's not just about women as people who have children, but women as people who have all kinds of different conditions that need care. They've actually set up a Women's Health Equity Fellowship I'll mention in a minute. And then the Department of Surgery has 7 different divisions, and I'll tell you a little bit about what each of the different division has been involved in. And so these are our primary countries that we've been established and partnered with for like more than a decade in each of these different settings, and then other country partners, institutional partners that we've developed over the last number of years. So the disciplines in bold are all the various divisions within the Department of Surgery. So we're doing things like, how do you build up skills where those skills are not available? So MIS is minimally invasive surgery or laparoscopic surgery. So when you do laparoscopic surgery here in the US, you go home much sooner. Your recovery is much faster. If you're working a job where you need to be there hourly, how many days can you take off work to recover from a big old operation? Hopefully, very few. And so a lot of places are interested in laparoscopic surgery. Well, how do you develop those skills? How do you teach those skills? How do you evaluate that you've learned those skills? Well, it turns out that actually needs a bunch of surgeons to work on. So that's a big focus. And Ray has led a lot of work there in Mongolia, which is not even on the slide anymore because they're doing this fantastic job just on their own now, and Cambodia, Ethiopia, and Ghana. A lot of work on trauma. I mentioned that kid with the injured leg. Well, trauma, it turns out, is one of the biggest causes both of death and of disability worldwide, that is a surgical condition. So working very closely across multiple countries to say, how do we improve those systems? And not just like, how do we do operations on that kid, but how do we prevent it? If it happens, how do you get how do you respond much faster? So I'll tell you a little bit about that in a minute. Surgical oncology, I mentioned breast and cervical cancer are key areas. Colorectal surgery is an important thing. These are all skills and disciplines that often don't exist. These specialists don't exist in many parts of the world. So how do you set up training programs to be able to mentor and upskill people in other parts of the world? Urology has a major program that's growing plastic surgery. You think of plastic surgery, like why would anybody want to know plastic surgery? Well, that same kid who gets hit by a car, that wound can get infected, need major resection, and have a major wound that doesn't heal. And that actually needs reconstructive services to be able to recover. Or around the world, burns is a big issue. Hand injuries are a big issue. If you can't work and you're an hourly worker and you've injured your hand, that can be catastrophic for your family. And so being able to do hand surgery, being able to get that person back to work is a critical thing. So that's all work that we're in the process of doing, many of our faculty in the process of doing worldwide. So I mentioned Ray and his work in several different countries. And that looks like, the way that looks is there's a lot of online content we're creating. There's a lot of assessment. How do you assess? And Leaf was one of our undergrads was sitting in the back there, has been involved in that. So how do you assess somebody's ability to learn, to acquire the skill? So that's the kind of work that we've been involved in. And then when you teach it, and then you say, okay, you've done 30 lap choles, which is a laparoscopic way of removing the gallbladder. What are the outcomes? What is, how many of those were there a problem with the clinical care? How do you know what's good? So you have to be able to assess that. And so that's part of the work that's ongoing. And there's a lot of groups that are interested in developing those kinds of training programs. And several of our partners in Ghana are working on that as well. I mentioned trauma. I'll tell you a little bit about some of my work in Rwanda, which is more to do with access to trauma care. So if you have a wonderful trauma surgeon in the hospital, it doesn't do you any good if your patient dies before they get there, right? So you have to think about, well, how do people access care? What are emergency services like? So number of years ago, I took my family to India, which is where I grew up as a kid. My son was 5 or 6 at the time. We had a respiratory, he had some sort of like an asthma attack. He had never had asthma before, asthma attack. Bright red, clutching his throat, can't breathe in a little child. And I had taken antibiotics, antiemetics, I had taken IVs, not occurred to me to take albuterol. But, so there, and my husband said, call an ambulance. And I looked at my family, I think we were there for a wedding. And my mom said, there's no ambulance here. We'll call a taxi. It's 5 o'clock. You're going to sit in rush hour for an hour to get to the hospital for a child in pediatric, like for a child in respiratory distress. I was completely useless, by the way. I was the only medical person in the family, completely useless. But we managed to calm him down, put him in a taxi, spend an hour on the highway, get to the hospital, get him some albuterol. He was fine. But it goes to show you those systems need to exist. And somebody needs to create those systems because they don't always organically develop. And so a lot of my work in Rwanda has to do with working with the division of EMS in the Ministry of Health to say, how can we more efficiently create systems to improve the care in that setting? Turns out they have already invested a ton of time, energy, effort, organization in setting up ambulances and setting up trained staff and setting up supply chains and a referral pathway. And so working on the next level it's still hard, but it makes sense. So that's what I've been working on and looking at time, pre-hospital time, optimizing time to care and understanding their system. We have a collaboration with the American College of Surgeons in Ethiopia right now to improve trauma training so that when that person gets to the hospital, they're met by somebody who's trained in trauma. And in quality improvement to say, how can we improve the care? How can we improve the system? Our new chair, Dr. Nwariaku, has a lot of work in Nigeria, and later this fall we'll have some speakers calling in and presenting from Nigeria on that work. One of my trauma colleagues here, Dr. Nunez and Dr. Price, have done trauma-related work in Mongolia to help them develop their trauma systems. So this is just a quick example on my work in Rwanda. So this is currently the process that occurs if somebody's in a car crash. You call the 912 emergency dispatch center. They get on the phone, they call the ambulance, and they send the ambulance over, and then there's more phone calls because the ambulance doesn't know where to go, because in Rwanda, as in many other countries, there are no street numbers or street addresses or house numbers. So how do you find the person next to the green mosque, third house down on the left side with a yellow roof in an emergency, right? So, and then what you do is you call, and then they find them, and then say, okay, great, we're gonna take them to the hospital. Which hospital? They have a bad traumatic brain injury. They need an ICU. They need a neurosurgeon. Closest hospital, do they have any of those things? No idea. You have to call, make more phone calls. Oh, we don't have it. You get there and you say, oh, actually our CT scanner broke. You have to go to a different place. So that coordination, you lose valuable time. So that's part of what we're working on, is trying to create a more efficient system that that we're working with the government there. We have funding from our government. We have funding from the UK government to try to create a system that works for the capital city of 1.2 million people in Kigali, just similar to the population of Salt Lake City, and then hopefully can scale up for the entire country of 13 million people. So it's not a small project. So this is sort of schematics of what that would look like. So that's a big project that actually one of our undergrads has been helping me with. Other projects, a lot of work on cancer access, breast and cervical cancer access. Dr. Price and a bunch of other folks just finished a countrywide survey of over 300 hospitals in Ghana to say, what kind of cancer care do you have available for breast and cervical cancer? Do you have a surgeon in the same place that has chemotherapy, in the same place that has radiation therapy? So you can offer all three things that are necessary for cancer care. Maybe you can, maybe you can't. Maybe you have one person here and one person there, and you can't actually like deliver care in a systematic way. So which hospitals would you invest in if you wanted to improve care? Which hospitals are reachable in bad weather so you can get cancer care, even if it's in the middle of like monsoon season? So that kind of work is what we're trying to do. Dr. Brownson's one of our best cancer surgeons. She's got several small grants with colleagues in Ghana. She also has been part of the tumor board, which is a multidisciplinary discussion to say, what is the standard of care that we can provide for this particular patient? And talk about complex cases. Dr. Huang and Dr. Pikran are helping set up a colorectal surgical fellowship in Rwanda. And I mentioned Dr. Nunez, and his work also has to do with surgical quality indicators in Utah. Because again, all of these quality indicators are for everyone, not just people in poorer countries, also for people in our setting, because we need to be held to the same standard, right? So, as I mentioned, a lot of the other divisions have a wide variety of other partnerships. And I have not mentioned, but I said we work social work and nursing and other departments or schools and colleges within the university. And so we have a wide variety of projects with them as well. Research is a big component of surgical care, because you got to like understand what the problem is. If you don't understand what the problem is, how are you going to solve it? If you're not collecting information on the problem, how are you going to solve it? So there are a lot of different types of research we're involved in. So like data science, which is looking at indicators, quality improvement, which is how do you improve systems, implementation research. So you have a great working intervention. How do you actually get people to use it? How do you scale it up? Epidemiology, surveys, the countrywide survey, as I mentioned, qualitative research, innovation. How do you develop something that addresses a specific problem? And those are areas, just like the software in Rwanda. That software exists in the US and in Japan. Will it work in Rwanda? No, because it needs street addresses and GPS data, which don't exist. So you can't just like import something from one place and drop it somewhere else and expect that it will work. These are just a wide variety of different grants and projects that we have ongoing in a variety of different places. Education. Many of you are trainees. You're interested in education. Like, well, but what are you doing from that standpoint? One of the key things we've done is is to create competencies and say, like, how do we teach this content? So let's establish what the rules are in this field. Let's work with the UN on developing content that people want to access. So those are things that we've been involved in. I mentioned the OB-GYN department's Women's Health Equity Fellowship, and right on time, one of the folks who just walked in is actually a fellow in that program. And Dr. Adolfo waved to everybody in the group, is an OB-GYN from Rwanda, from Kaciro Hospital in Kigali. And he's a Women's Health Equity Fellow in the Department of OB-GYN. We typically also have a US fellow who spends a year in the Indian Health Service and a year in Rwanda, thinking about healthcare across different settings. And he and Dr. Daisy and Mrs. Mary in the back here are all students who are in the Masters of Clinical Investigation Global Health Innovation track. And Leaf, I forgot Leaf back there. Trying to work on how do we develop solutions to needs in various places. And then we have various School of Medicine activities, various courses, short courses. We're part of the Office of Global Health Education certificate, if any of you are in that track. We have an asynchronous course that we're putting on Canvas that will hopefully be for credit at the School of Medicine and at the university in the next year or so. There are a number of surgical related courses. So surgery and public health course is an important course that's part of that graduate global health certificate. The Global Health Student Alliance, we work with them closely to try to put on more of these types of seminars or journal clubs, things like that. Residents and fellows, we have various pathways for them with various ways to get them involved. We even had a high school student this past summer work with us on something because they were available. So like, great, fantastic. And we have students from other programs who are interested in how do you deliver surgical care? What about surgical policy? What about geographic access to surgical care? How would you study that? So a wide variety of different things like that. As I mentioned, this master's in clinical investigation that several people are in the audience, that's a master's program here with the Clinical and Translational Science Institute to work on not just identifying problems, but solving problems. How do you think about solving them? And then we have, a few months ago, we had an innovation showcase. People who worked on different ways of solving problems present their work on what they've been working on. And that's, again, with other departments, biomedical engineering, medical innovation, folks like that. And we've historically run a conference called the Extreme Affordability Conference, where people are interested in innovating for low resource settings. And we're slowly going to start getting that back up and running now post-COVID, as people can be engaged. We have a lot of content for people who are like the folks in Cambodia and Ethiopia who are trying to learn laparoscopic skills, trying to learn a variety of different things. Programs here to bring in faculty and trainees from other places. And so let's talk a little bit about sort of what activities are upcoming and what are things that are happening. So as I mentioned, this Works in Progress series is a bunch of different talks. We tend to discuss projects and see, what is the progress on all these different projects. We also have speakers. So our next speaker, Dr. Kehinde, will be talking about emergency systems in Nigeria. And Dr. Bodohoski is one of our neurosurgeons who is helping set up neurovascular training in Eastern Africa to look at stroke care. And so these are just a wide variety of different folks who are going to be speaking in the next in the next like 2 months. And you're welcome to join online if you want, or if you feel like there are speakers that we should have, let us know. And I think it would be great. With the medical students, medical students and residents, we try to have quarterly journal clubs to talk about interesting papers that have come up and try to make it multidisciplinary and do it on Zoom. So it's not, you don't have to worry about trekking somewhere. You can sit at home and, sit on the couch and put your feet up, and you can still be a part of this community. And so that's something that we're going to get organized again now that the academic year is starting. And we try to typically have different disciplines so that we're talking about work from around the world. And the times are a little flexible because we want to have as many of our global partners involved as possible. It's hard to do it at 6 p.m. and have them involved. So we'll try to balance that. And so that's all I have. And then this is just a bunch of our staff, several who are here, like Liz and Hafsa just went to a breast cancer meeting, and folks like that. So questions, thoughts, comments, anything that I said that was interesting or not interesting?